Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Welcome to this edition of the Chest Journal podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the distinct pleasure to discuss a very interesting article, which will be in this edition of the journal, by Dr. Luis Felipe Reyes and colleagues. The title of the article is Pseudomonas aeruginosa in Patients with Nosocomial Respiratory Infections, a secondary analysis of the European Network for ICU-related respiratory infections. Felipe, thank you so much for joining us today. For the benefit of our audience, could you tell us a little bit more about who you are and where you work?
Yeah, thank you, Matt. Thank you for the invitation. And yeah, my name is Luis Felipe Reyes, as you said before. I'm an ICU clinician, and I'm also a clinician scientist. My main expertise and focus in my research has been the severe respiratory infections and sepsis. I'm based at the Universidad de La Sabana in Colombia, where we have our hospital, which is called Clínica Universidad de La Sabana. And there I lead the Unisabana Center for Translational Science and my research group that is called Translational Science and Infection Diseases and Critical Care Medicine. I'm also hold an appointment at Oxford University in the Pandemic Science Institute. And there I work as a senior researcher working in pandemic preparedness and sepsis and, again, pulmonary infections. Thank you so much for the invitation.
Thank you, Felipe. Wow, that was a great overview of everything that you're doing. It sounds like we couldn't have a better person on the podcast to talk about a topic like this. So to start with, give us a little background about this problem. What did we know about Pseudomonas nosocomial respiratory infections before this study?
So one of the main questions that we always ask when we are in front of a patient with a pulmonary infection is, what is the etiological pathogen? And we try to use data coming from community-acquired pneumonia and other kind of syndromes to try to extrapolate what is the most likely pathogen that is causing the infection. But when you take a look to the nosocomial infections, then the etiology of the pathogens change a lot. And now we know that the pathogens that we see in nosocomial infections are different to the ones that cause community-acquired pneumonia or community-acquired infections in general. And what the guidelines tell us is that it's important to make sure that the treatment that you choose cover the most prevalent pathogens that you see in your ICU. And we as intensivists, I'm positive you might experience the same thing. We are always asking the question, is this Pseudomonas? Is this patient that I'm seeing right here with a pulmonary infection is because he has a severe Pseudomonas infection? But then when you take a look to the data, first of all, the data available has several limitations, methodological limitations. And then you can see, okay, the prevalence of Pseudomonas in nosocomial infection, in nosocomial pneumonias is not that high. So why we always treat the patients empirically with anti-Pseudomonas antibiotics? And that's the first question that we ask, okay? It's like, okay, let's try to generate something that is multinational, something that is recent, because the data that we have is quite old. And then try to identify the prevalence of Pseudomonas as the etiological factor for nosocomial pneumonias. And then we move a step further and say, okay, once you have those patients with Pseudomonas, which are the characteristics of these patients, meaning clinical characteristics? Can we predict that someone will have Pseudomonas as the etiological pathogen in nosocomial pneumonia. And that was the reason why we said, okay, this is a really important clinical-based question. Let's do something simple to try to answer it. And that's why we developed the NERI study.
Thank you for that overview. I think you really hit the key issue there, which is when we're encountering patients like this that are at risk for hospital-acquired or nosocomial infections, what is the likelihood of Pseudomonas, and what are we doing to identify these patients? So I think you nicely covered the background and sort of the inspiration for this question. Now that you kind of gave us the framework for the problem and the basic idea of the design, could you give us a little bit more details about the study design itself and maybe some of the statistical methods, since I found them personally to be very robust?
Thank you, Matt. Yeah, so the study design is pretty straightforward. We put together a network of 12 countries with ICUs, both private and public, university associated versus regular hospitals. And then we proposed the NERI study, which is a prospective multinational, multi-center cohort study of ICU patients with nosocomial respiratory infections, as I said before, in 12 countries, most of them in Europe and Colombia in Latin America. And then we enrolled patients during 3 years between 2016 and 2019. Then COVID arrived and everything switched to COVID-related research questions, as you know. But then we were able to enroll more than 1,000 patients with ICU nosocomial respiratory infections. These patients must underwent for microbiological testing, and then we identified those that had a Pseudomonas infection as the etiology of the pneumonia. And then we stratified the cohort in two subgroups. The first one, Pseudomonas pneumonia, and the other one, as expected, no Pseudomonas. And then we tried to develop a very robust statistical analysis. We exclude or we remove all the variables that have more than 30% of missing data. And then we use of course, the nearest neighbor imputation strategy for those with less than 30%. And then we started selecting. So then at that moment, you were able to establish the prevalence of Pseudomonas pneumonia in patients with nosocomial and pneumonias. But then we moved to the identification of the risk factors, and for that we started with the lasso regression that allow us to identify the predictors, reducing the overfitting of the model. Then we did sensitivity analysis using elastic net analysis, which is a robust strategy. And then we train a random forest, which could be considered one of the artificial intelligence strategies to evaluate the importance of the different variables. So we select them using the lasso and the elastic net analysis, and then we categorize them per importance using the random forest. And then we convert all of that in something that we can interpret in the clinical practice, which are the classical risk factors adjusted, of course, by the Hosmer-Lemon show and other different variables or the different strategies. But overall, we convert all of that to hazard risk, and the risk factors were established using that strategy.
Great. Thanks for that overview. That was very nice. Sort of look at how we take, a large observational data set and try to draw more robust conclusions about risk factors. So now that we have laid out the groundwork for that, can you tell us what were the key takeaways from this study and any hypotheses that you might have to explain results, particularly things related to like the risk factors that you all identified?
Yeah, of course. So the first conclusion, and I think one of the most important ones, is that Pseudomonas aeruginosa was not that frequent as the etiology of nosocomial respiratory tract infections. So we found that the prevalence is around 14%, and that's in the overall cohort. But then when you see or when you take a look to the subjects where a pathogen was identified, so the denominator changes, and then the prevalence goes up to 21%, which is low. I mean, if you think about it, when you're in front of a patient, for you to say that 1 every 5 patients will have Pseudomonas, then you can argue that the majority of them, 70% of the patients, will not need empiric anti-pseudomonic coverage, and that's I think an important point. The second point, that we went and take a look to the participants that receive antibiotics that were anti-Pseudomonas, and then we found that the vast majority received antibiotic treatment that was unnecessary, meaning up to almost 60%, 59.5% of the patients receive anti-Pseudomonal treatment without Pseudomonas infection. So that's something that is important to keep in mind, because it has a lot of implication from the stewardship point of view, and also for the safety of the patients. And then we moved to the risk factors, and then we found that COPD GOLD was an independent risk factor. We also found that active autoimmune disease was a risk factor. Chronic kidney disease was also a risk factor. And then acute kidney injury at day 1 was also a risk factor. So all these factors make sense, at least from the pathophysiological point of view, because we know that COPD patients are frequently colonized by Pseudomonas. So, and actually in another study that we ran in community-acquired pneumonia, we found that COPD was indeed a risk factor, even for those patients that are not admitted to the hospital. So yeah, let's say COPD, it was expected. We know that. We know Pseudomonas changes the mucociliary clearance, is associated with frequent COPD exacerbations and many other things. So for us, that makes sense. Then when you take a look to the autoimmune diseases, that also makes sense. We know that the Pseudomonas is a frequent etiology of infections in this group of people, and specifically pneumonia pneumonia due to Pseudomonas is pretty frequent in patients with active immune disease. Then chronic kidney disease. We know also that the chronic kidney disease may have an effect on the immune system. These patients with chronic kidney disease, many consider as immunosuppressed patients. They are also in a lot of contact with the healthcare system, which we know also is a risk factor for people to develop Pseudomonas pneumonia. And then the final one was the acute kidney injury at day 1. And we hypothesize that this is mainly related to the severe infection or the severity of the disease. So we hypothesize that those that develop acute kidney injury at day 1 are those that have the highest severity among the patients, and that's why we think there might be a close relation between disease severity and the acute kidney injury at day 1. So I think overall those are the main points. The low prevalence of Pseudomonas, the overtreatment without the Pseudomonal treatment in patients with nosocomial pneumonias, and then the four risk factors that I described, and how this could be explained from the pathophysiological point of view.
Really interesting information here. I think, from the start, you're telling us things that I think are going to change the way that people think about patients with nosocomial infection. Most importantly, the prevalence, which is probably lower than what some people would otherwise perceive it to be. And seeing these risk factors being things that have some sort of biological or medical plausibility behind them really strengthens the results. What words of caution do you have for the readers in interpreting these results, especially with regards to any limitations there might be?
Yeah, I mean, this is an observational study, and of course we have important limitations that are important to acknowledge and for clinicians out there to consider when they are deciding which is antibiotic that they want to use, not to base only their decision on this study, because we have limitations. For example, this is a secondary analysis. The main analysis was published a year ago or something with this cohort, and the overall objective of that study was to characterize the different kind of nosocomial pneumonias that we can identify. But the study was not originally designed to characterize the Pseudomonas pneumonia and to identify the risk factors for this pathogen. So the sample size might be underpowered. So it's something that is important to consider. Another important point to consider is that we did not have a standardized microbiological assessment in all the sites. So even though they use the strategies that they use normally for clinical practice, we know that the technologies available in Colombia, for example, are different to the ones available in the United Kingdom. So now we know that the rapid diagnostic tests or the PCR based technologies are widely available after COVID, and most likely the majority of clinicians are using now these technologies. But at the moment that we did the study, we have different technologies, and these were not comparable among different hospitals. So the prevalence could be different if you use a standardized microbiological assessment. But we did not that in this particular study. Also, it's important to consider that the four risk factors that we identified, when we put them together and generate the model, the discrimination of the model was fair or borderline. It was around 0.7, which we know is not very robust, and maybe this is because the study was underpowered from the beginning. Another important point is that we did not adjust by country or by center, and this is important to consider because it might be possible that some of the sites enroll a larger number of participants, and that particular site or those particular sites could be the ones driving the results. But we don't have enough sample size to be able to control and do stratify analysis. But overall, I think those are important limitations to consider. However, it's also important to consider that this is one of the largest multinational studies with nosocomial pneumonia available in the literature. So we know that it has limitations, but we also know that this is what we have, and it could be used not as a unique or as the unique tool for clinicians to make their decisions, but it could help them to decide which is the best treatment for their patients.
Yeah, thank you. So now that we've gone through sort of the meat of this paper, if you're a clinician reading this, Felipe, what do you do with these results, or how do you think clinicians should think about Pseudomonas risk factors and treatment in patients with suspected nosocomial infections?
No, I think it's important to always ask the question, is this Pseudomonas pneumonia? Because otherwise, if we treat all nosocomial pneumonias as the same, then we are trying to provide the same antibiotic treatment for everyone. And we know that is not appropriate. We know that there is robust data showing that you need to provide an individualized treatment for everyone. So the pneumonia is already a very heterogeneous syndrome. So you need to provide a care that is individualized for everyone. And then, so the first question that clinicians should ask is, okay, what is the most likely pathogen of this pneumonia in particular? And then after that, you need to ask two questions. Is this Pseudomonas pneumonia? And the next one is this MRSA pneumonia? Because those two questions will guide you if you need to generate or if you need to treat the patient with anti-Pseudomonas or anti-MRSA treatment. And to establish that, it's important to take a look to the local epidemiology. So how frequent do you see Pseudomonas pneumonia in your environment? With the data in mind that 1 out of 5 or 1 out of 6 patients will have Pseudomonas pneumonia. That's what this paper is showing, right? But then you need to ask the individual risk factors. So if it's a patient with severe COPD and a patient with severe nosocomial pneumonia, then most likely the patient will benefit of anti-Pseudomonas treatment. But if it's a patient with no pulmonary infections, with no autoimmune diseases, with no immunosuppressants, then the likelihood of this case in particular to be Pseudomonas pneumonia is lower. So my point is try to individualize every time that you decide an empiric treatment. And on top of that, use the available technology. So start narrow based on the risk factors, and go for a microbiological identification that could that can give you the result quickly. And that way you can adjust the treatment based on the microbiology. But if that technology is not available, I mean, using the risk factors is the best way to go to try to provide a narrow antibiotic treatment, but narrow enough to cover the most likely pathogen. And I think that's important. I mean, one size does not fit all, and that's important in pneumonia. Pneumonia is a heterogenic disease, and it's important to individualize the treatment and not to treat them all with the same recipe. It's important to individualize that.
Thank you, Felipe. That was a great overview. I'd just like to emphasize a couple of things that you said is you have to understand the patient that's in front of you based on the risk factors, not only specific to them, but to the hospital, the antibiogram, a whole litany of factors there. So this is a really nice paper to help us frame our clinical decision making. So thank you so much to you for being here today, and thanks to you and your co-authors for doing this really, really important work. Any final thoughts for our audience?
Thank you, Matt. No, the final comment could be that remember that Pseudomonas pneumonia is frequent enough for us to learn about it and to identify which is the best treatment for them. But it's infrequent enough for you to ask the question: is this really Pseudomonas pneumonia? Is this patient at higher risk? And based on the different factors of the risk factors and the local epidemiology, make an informed decision, right? Do not treat all patients equally. Take a look, wait and think in the risk factors, wait and think in the prevalence, and avoid over treating patients that do not require this coverage, because at the end it's going to be bad for the antimicrobial resistance in your particular hospital, and you might expose the patient to an antibiotic that they don't need. And at the end, it must be the balance between risk factors antibiotic stewardship strategies, and of course, always thinking in what is best for the patient. And I think that's the key point. Keep in mind that your patient is the most important thing, and try to provide the best care, not following a recipe, but to providing individualized treatment for each one. Thank you so much, Matt.
Thank you so much. Dr. Luis Felipe Reyes, talking about our study for today, Pseudomonas infections in patients with nosocomial respiratory infection, a secondary analysis of the European Network for ICU-related respiratory infections. We'll see you all next time. Thanks for joining us.